Exactly. No, you're right. And I think, we had a bit of a space race when it came to AI.
Mm.
So you had these hospitals last year, they had like 80, I read an article that said one academic uh, medical center had 80 AI widgets, software solutions,
Yep.
whatever you want to call it,
Yep.
last year.
I know where you're going.
This year, they now have 200.
Yep.
And we're only in September.
Yep.
So they're probably going to be up to 250 by the end of the year.
Yep. Hello, and welcome to Haverin About, our brand new podcast where we mix stories, some health information technology strategy, and a fair bit of Scottish-style blethering. I'm Stuart Miller.
And I am Bethany, his daughter.
Excellent stuff. Well, before we get started with today's topic, I was kind of curious this week in terms of what in the news caught your attention or in your life as you were sort of navigating through the past week.
I have been slowly binging the Pitt, which I'm late to it. I know I'm late to it. I know. Well, I have an almost 5-year-old. She's not interested in watching the Pitt, sadly. But it's convinced me that I low-key maybe should have become a doctor. Because there's been 3 cases where I'm like, clearly it's this. And it's turned out right upper quadrant pain. I was like, gallstones. And I was like, I think that was too easy of a diagnosis. I bet you something else is going on. He did. Heart attack, died.
Yeah.
And then the baby came in and they were like, oh no, they don't know how to fix this baby. We're doing all these tests and meningitis.
Yeah.
The minute I saw socks on that baby, I said, that baby has a hair tourniquet on her toe.
Yeah.
And oh, look, and it turned out, and
yeah,
and you know how you get rid of it with Nair, with
you melt it
with that cream to melt the hair away.
Yeah.
So I'm now like, should I go back to school and become a doctor?
And I should.
It's just as easy as that, right?
I should explain to our viewers, this is a decades-long Miller family tradition, because when I first met Sarah, Bethany's mom, and we, my wife, still my wife, I should lead with that. But when I first met her, we were both in nursing. And there was a show in the UK called Casualty that had just launched on the BBC. And it was your archetypal emergency department show, 3 cases of the week and then drama within the team. So we've been playing this game of, I wonder what they're going to do with this one for, I can't even remember how old Casualty is now, about 40 years. Probably something like that. It's probably something like, because it predated you and Jamie, so it's got to be something like that.
When I remember, and I mean, I was watching the show at 7.
Yeah,
8. It's not like I probably shouldn't have. It wasn't that gory.
No,
because it was on BBC, so it's not super gory. Yeah. But there's definite blood, and I remember there was one where they had to take a pen and pull it apart for the tubey bit.
Yeah.
They shoved the tube in to let air out.
Yeah.
And that was another one that was on the Pit. They were like, oh no, there's air collecting. I was like, just get a biro pen and shove it in. And they didn't use a biro pen. They use a scalpel.
They've got cool tools for that
actual
now.
medical devices.
Yeah. Awesome.
So I just, maybe I should be a doctor.
Well, and I will say in kudos to the Pit. I think that
such a good show.
The drama, number one, the medical accuracy of a lot of the cases is so good. I mean, we've got a lot of experience of being in the clinical area, not only as a clinician, but also as a patient. And so therefore, and I've had some pretty high acuity stuff done. And in our family, we've had other family members who have been pretty sick. And so therefore, we've got quite a lot of experience with some of that stuff. And I have to say, we watch some medical stuff and it is you shudderingly bad when it comes to medical accuracy. The Pit is not that. Whoever their advisors are doing a sterling job. And I don't mean just the medicine. I mean the nursing and even some of the kind of hospital administration drama. But I got to say, while number one, kudos, dude, for leaning back in on, being an emergency doctor later in your career. And I will say it was marvelous to see him do his shout out to Figs the company that makes scrubs and is very well known in the healthcare provider industry, by having them make that tuxedo for him. I thought that was an excellent shout out to all of our healthcare warriors.
Yeah. And to be clear, I could not be a doctor. Like, absolutely not. Could I diagnose a hair tourniquet on a toe? Yes. That is the limit of my. We joke we're medically literate.
Yes.
But we are not clinicians.
Highly
a lot of respect
literate,
for the people that have actually studied this and know what they're doing.
Yeah, 100%. Yeah. Well, on that happy topic and AI replacing doctors and Stuart and Bethany not replacing doctors, maybe we should go on to talk about today's topic.
Yes, today's topic is cutting through the AI FUD in healthcare. AI is everywhere in the world, in life. I used ChatGPT this morning to make coloring pages for my daughter's birthday party this weekend. They're very cute. I'll see if maybe on YouTube we can put an image of them. They're very cute. So AI really is everywhere, right? And if you go to any of the conferences, I went to one in Europe this summer. I went to another just this week in Atlanta. All the booths, artificial intelligence, just everywhere. AI.
Yeah, we are definitely in the full throng of an AI hype cycle. And it is, I think it's very confusing for a lot of the people who are interested in how the technology can work in healthcare and how it can have a meaningful impact, not just on clinical care, but on hospital operations in lots of different ways. But also for the vendors to try and work out, how do I position my solution, my AI widget, against this landscape? And how do I differentiate? How do I deal with the fears, uncertainties, and doubts, the objections that are going to come up from the other side? How do I navigate that space to be able to be successful with it?
When it's difficult, because I think you've got people on two, like all things in life, two very extreme points of view. You've got the people on one side who are saying AI is going to replace doctors. We're not going to need any nurses in 20 years because everything will be done by a robot. And we will just trust computers because they'll be able to diagnose because they have access to all of this information that, a regular human could not contain in their brain. And then you have people on the other side going, well, no, I want to do everything manually because then it's me touching it and I know what's happening and I don't trust AI and I don't want AI and it's absolutely not. And as with all things in life, there are the extreme points of view are fine, but the truth and where you're really going to find success is somewhere in the middle. We're not going to replace doctors anytime soon. But we're also not going to sit on the sidelines and not let advances in technology really help us in our life and in our work.
Yeah.
If AI can help to save someone's life, we need to be using it.
Absolutely. Yeah. Yeah. And I think that it is kind of interesting because it's one of the things that we might touch on a little bit more in depth in a later episode. Is there's an analogy that's used, and it's actually been it's existed for some time, and it's been used in the science fiction context as well, which is the centaur cyborg balance, whereby fully handing over to AI is equivalated to being like a cyborg. The AI is so integrated, it's taking over elements of your brain function, not just helping empower you. Whereas the centaur model is that analogy of the two components working together, but this human part of it still being very much in charge. So that being the torso and head and brain, but taking advantage of the power of the lower part being the horse part. So that's a very interesting analogy that we might explore a little bit more deeply in another episode.
So we just need horse bodies now.
Well, if you look at some of the stuff in terms of the mechanized robots that are now coming, how far are we away from having mechs? Like Sigourney Weaver in Alien or the many other science fiction films that have been there. The answer is not far. I do woodworking, And there's a German company called Festool, who already have automated powered like arm limbs to assist. And they're designed for people who do a lot of construction work with their arms up like this, up on high places like ceilings, and doing light fittings and doing wiring runs. And the whole idea is that instead of taking their hands all the way down and shaking to get blood back into the muscles, etc., they're able to just relax them, so the muscles aren't so tense that the blood can flow into them. But that technology is available. You can buy that for about $2,000 to be able to sort of like do it, and it's powered by plug-in batteries, just like your DeWalt drill. And so that kind of technology is already there. So the Centaur model is not that far away. The only thing is, I don't think there's AI in there that's deciding, which direction your arms should move and what you should do next, because that truly would start to become like cyborg arms, that are totally robotic.
And then the AI takes over, and then the AI throws the wood at your face. And it's like, no, it's terrible.
Yeah, and then Skynet occurs, and then the Terminator. Yes, I know. All the
end of society,
the end of humanity. Yes.
Luckily, we are not there yet, right? AI is definitely, as you said, in the kind of upper bit of the hype cycle. I don't think we're at the very tippy top yet. I think there is more to come. But I think suddenly everyone is kind of looking at artificial intelligence and saying, okay, what do we do with this? Okay, we know that it's useful. We know that there are some incredible use cases in healthcare. I mean, if you walk around any of the big conferences like Health and Vive and HIMSS, and you go and talk to all of these little vendors who are doing amazing things, whether it's, they're automating and using AI on one little piece of the workflow or one little piece of clinical decision support. It's incredible. And if we could just bundle them all up and pop them in a hospital for a good amount of money, it would completely revolutionize how medicine is delivered.
Yeah.
But we can't do that. It's not realistic from a financial perspective, from a change management perspective, from so many perspectives. So I think
also,
today,
one of the big issues, is a lot of hospitals are risk averse because, and people always equate to the aviation industry, where if a mistake happens, 300 people die, et cetera, et cetera, et cetera. So there are lots of controls there. The challenge with medicine is it's infinitely more complex from a decision-making and data points perspective as to what you're doing. And so actually the potential for an error having a fatal outcome are infinitely larger. And they may only affect that one patient, or actually they may affect a whole cadre of patients because you've programmed something wrong and it isn't spotted until it's affected several hundred patients. So I think that healthcare is very, very risk averse. And so therefore, when you are looking at how do you address that, their tolerance for potential error is significantly lower than it might be in other places. And so I think that's one of the things that as you're thinking about how you position, particularly if you're trying to bring a technology that has worked very well in another industry and apply it to healthcare, it's not that simple. And we'll probably cover that a little bit more as we go through this conversation.
Yeah, well, let's dive into that. Let's look first at the hospital buyer's lens.
Perfect.
And we know that is not buyer apostrophe S, that is buyer S apostrophe. There is not one buyer.
Yes.
There is a whole army.
All your sales methodologies that says, oh, you only need to go and talk to the guy who signs the check or signs the approval.
Find your one decision maker.
That's not how hospital and health systems work. They are huge branches of committees that actually you have to sort of navigate your way through. If you're enjoying this episode of Haverin About, the best way you can support us is really simple. Click like, leave a comment, and subscribe wherever you're listening or watching. It really helps more people find the show, and it means an awful lot to us. Now, back to the show.
Absolutely. And you actually posted a great Substack about this in the last couple of weeks about the knights who say no. And
Yes.
we'll put a link in the
Showing
description
my affection
here.
for Monty Python there. Yes.
Everyone loves Monty Python. But it really was. And it's, saying no sounds so defeatist and definite. But there's a lot of reasons why somebody might say no, right? So there is the financial aspect, there's clinical, there's compliance, there's privacy, there's security, there's workflow, there's change management, I just don't want to do it now because we have too many other things going on.
That's not a
there
priority because we're opening a new wing.
No.
Yes, yeah.
Exactly. So there are so many reasons. But I think, Dad, what do you think a hospital leader, when they are being pitched an AI solution from either a new company or an existing partner, what are they thinking about? What do you think is top of mind for that hospital buyer?
I think it is that kind of risk reward analysis that says, well, okay, so this sounds very cool. What you're pitching me sounds great. It sounds awesome. But, one, what's the risk that I'm introducing with this tool? How is it going to change things? Secondly, you're telling me it will have this impact, but have you got any proof that says that'll definitely happen? There's an article I wrote, which was a kind of post-mortem of Olive Health, a company that was a super rock star, incredibly well-funded unicorn that in the space of about 3 years rattled through $1 billion.
So much money.
Of promising stuff and then not delivering it. So when you look at that as a case study of, the kind of promise that was made, and it was very frothy. A lot of people were very interested in what Olive Health were pitching. But the challenge was there was nothing in the other side that actually resembled what they were pitching. They had acquired some other like legacy technology along the way, some robotic process automation type stuff. And they were selling that, but then they were trying to pitch it as if it was, some very cool state-of-the-art, AI-driven workflow stuff. So when you look at that as a context, there's lots and lots of experience of these hospital leaders whereby they've been made promises before. So they're pretty skeptical when it comes to sort of stuff that is promising a big ROI that is in cash dollar terms. Even more skeptical when it's something that actually is delivering intangible benefits, i.e., well, this will actually save our doctors 3 hours a week. Okay, so each doctor's going to save 3 hours a week. What are they going to do with that time? Because believe me, I have enough trouble hiring doctors, right, and filling the vacancies I have to lay off doctors. That's not even on the table. Yeah. So you saving me 3 hours a week, that's great for them, but it doesn't have an impact directly on the way the hospital works. And if I'm in a non-US marketplace, actually the demand-driven side, if you're state funded by the government will just expect you to, well, okay, treat some more people that are sat on the waiting list, shuffle them through. So I think that's on that dynamic. Now, on the other side, they'll also be looking at what is going to be the impact on this, and is this going to create, let's say it's very successful and well adopted, is that then going to drive up the budget for the use of this? And that's one of the problems you're seeing with a lot of the generative AI stuff, is that suddenly the unit cost of this is making the cloud budget go up, because suddenly you're accessing a lot more data, you're storing a lot more data, you're having to do all of these other things, you're having to apply other pieces to try and make it safer. So as you introduce more technology, suddenly your infrastructure cost goes up and your utilization cost goes up, because the doctors are suddenly going, oh, I quite like this is quite good. And so I think that there's going to end up being some assessment by a lot of these hospital leaders of, well, who do we allow to use this and how much?
Yeah.
More because it's got a downside whereby even if it's got an ROI, is that ROI to get there going to actually cost me more? Because to get there, we're going to have to consume more in terms of infrastructure to get there. So total cost of ownership.
And that's the big secret. The secret that I think everybody knows is all the big cloud platforms that exist today. And I've sold in partnership with most of them.
Yep.
Definitely AWS, Azure, and Google. I've sold in partnership with them, side by side, buy my thing. All they want is consumption, cloud consumption. Yeah. Is this going to drive cloud usage? Are they going to use more AWS servers or Google servers or Azure servers?
Why did Oracle's stock price jump 40% in one day? It's because they came out with some predictions, not results, predictions of what the growth of their cloud consumption was going to be, driven by AI adoption. And that was enough to make investors go, oh man, this is awesome. So that increased consumption is going to have to be paid by somebody. And hospitals don't have the ability to just go and create inelastic revenue. They don't have the ability to grow that. They typically are kind of relatively stuck in terms of how much revenue they can have. And the government and the private insurers are all trying to push that down. So therefore, you've got a challenge whereby to be able to address more of this and consume more of this means that you're dealing with an inelastic budget on the income side. So that's the other. Again, we're back to talking macroeconomics here, but we're looking at this from the lens of a hospital buyer, and the hospital buyer as the CFO is going to be looking that way.
That can't keep growing exponentially. So I think if you, and this is kind of veering more into our next, well, it's a very nice natural transition
let's go there.
Into the seller's lens of if you're already in a hospital, in a health system, you are going to be scrutinized in the next 12 months because suddenly someone up there, one of those knights, or maybe one of those knights' bosses is going to go, hold up. What does this do? What are the results? What is actually happening here? Why has our cloud consumption cost gone up? What did we get out of that? So if you're existing, you're going to have to really prove your worth in the next few months as your renewals are coming up. On the flip side, if you are going in, it is going to become significantly harder.
Yeah.
Because people have suddenly realized like, oh, this is, patient data. This is financial data. Maybe we shouldn't just be trusting all these little companies that have only just popped up in the last few months in some cases. Should we really trust them? So I do think there's going to be very much a pushback. And it's going to start with the big health system. It always does, right? The poor rural hospitals barely even have one AI agent.
Well, exactly.
One AI widget by now, but
and I think that's the thing. There is a big disparity as well. I mean, in the article I talk, and by the way, the article that I wrote, The Knights Who Say No, and when again Monty Python. The reason that I wrote that was I was inspired by another article, a LinkedIn post by a CEO of a startup actually in Canada who was addressing exactly this issue of how do you create the link between value that you're delivering and the solution that you're bringing and being able to argue that case with hospital leadership and on from there. And I wrote the article because he gave a couple of examples of the obstacles that are there. And I said, having worked, because I think, those of you who know me, I worked for a long time on the vendor side of things, and I now work for a large health system. And now that I worked inside the beast, I now understand so much more. I always knew, I was always quite a strategic seller. And so I knew that there were these committees and things. I had no idea how Byzantine and how bureaucratic some of this was. If you look at it and you've got a doctor who's very excited about your product, let's just take a scenario, and they say, I'm going to go to procurement and tell them I really need to have this. Here's what will happen. Procurement will have a bunch of their stuff that they want you to jump through, and you'll go, oh, that's not too bad. There's a list of things, etc. Then procurement will defer. They'll send it off to IT, to the enterprise architects, and say, hey, can you check some boxes and make sure this fits with our general architectural direction? And then the enterprise architects will get into it and they'll go, oh, wow. And the enterprise architects will say, has this passed through CISO, which is the Chief Information Security Officer, and whichever set of committees they've got? Mm-hmm. And then suddenly it needs to go there. And then they will go, well, CISO will go and assess it for information security. And they'll say, has this been through compliance? And then the compliance group, the legal compliance group, will get involved in terms of looking at what's the impact of this and so on and so forth. And they will have a whole set of checks and balances. And then they will defer and they'll say, well, has the clinical body approved this? And they will send it off to something that has been around for decades now, which is called the Pharmaceuticals and Therapeutics Committee. The P&T committee is normally what it's shortened down to, which is a group of doctors who all sit there and go, well, we have to consider keeping a balanced, sort of viewpoint of what is the standard of care here in this organization. Mm-hmm. And they will act as a kind of regulator to say, well, we're going to balance this out and say, well, this is an approved practice and this is an approved medication and this is an approved implant. And so they will come up with their set. And then if it's something novel that they haven't come across, like AI, then they're going to go, well, we need to do a study and actually assess what the potential clinical benefit versus risk is here. So we're going to send it to Institutional Review Board. And suddenly you've got a new committee is involved. And IRB are then going to go through. The important thing about those last, you may have thought everybody up until that point was fairly bureaucratic and, sort of more than my job's worth to let something get purchased. The thing that is fascinating about the politics inside P&T committees and the IRB sort of like oversight board is they typically are staffed by some of the longest serving and therefore most conservative and then most Luddite, if you want to sort of like take a point of view on it, of the clinicians that are in the hospital. So you have this great champion and he, this doctor is up against the machine. It's not just you, it's him as well, saying, here's a technology that I want to move forward. And he could be quite senior. He could be, I always remember being told you should look for who is the clinician that generates the most revenue for the hospital. And it was always like, it was all the cardiovascular surgeons or the transplant surgeons, or it was the people that were generating big money. And that depended on
if your champion is a primary care doc.
You're struggling if they are employed inside the health system. So I think that my point is that when you are looking, and this particularly applies to early stage and startup organizations, you've got to not be naive about what that political minefield is that you're stumbling into. And just because you think you figured it out at health system A, it could be very different, not just because of the personalities involved, but they could be structured differently. They could have some little side committees that are actually involved as well. So mapping that out early and understanding it is very important, because you can't expect your champion doctor, because their day job is caring for patients. And even if they've been in an organization for 10 years, if this is the first product that they've sponsored through saying, hey, I'd really like us to adopt this, they may be naive about all of this stuff because it's not typically transparent to people who are working on the front line. So,
When I think as a seller, what that teaches you, or what that should guide you to do, is you have to not only find the right champion and map out all of those relationship maps and the decision trees and things that we've been doing for years, right?
Yes.
I've done that my whole career. But what's different now is you really have to be an educator.
Yep.
So you got to sell, right? And turn up and do the song and dance and show off your nice shiny demo. But you've got to explain it in such a way that your champion can go and explain it. And if you get that little 5-minute coffee meeting with someone who's on one of these boards, or you run into them in the hallway, you've got to know, I have 30 seconds to say my most important things. And if they're approving everything from supply chain workflow to new implants to, I don't know, the lawn care company that the hospital uses, they are not experts in any of those fields necessarily. So they may not be an expert in AI. So it is your job to educate what's really going on. And I always have been very transparent in my career about the risks, right? You have to explain not what can go wrong with your software. That sounds like you don't have good software, in which case you should probably find a new job and a new company. But if your software works, but you do need to explain limitations.
Yes.
Right. I have been in so many sales meetings where sellers will just sort of bend the truth and be like, yeah, I could do that. No, you have to be just so transparent about what your product does, what its impact is. You need to know the technical details. It is not okay to just rely on your solutions architect or your solutions consultant. You really have to be an expert enough that you can confidently explain your solution and the value that it brings.
If you'd like to support us a bit more directly, we'd love to have you as a paid subscriber over on the Substack. Or you can buy us a coffee on Ko-Fi to help cover some of the technical costs of keeping this podcast running. Links are in the description. Now, back to the show. I provide coaching to product managers now. It's a part of my new life. So it used to be I managed and, cracked the whip over sales teams. But actually, I now, I sort of like I've studied with Pragmatic Institute, who are a well-known training and consulting company in the product management world. But one of the things that they often talk about, and I know salespeople consume these, even though product management might come up with them, is kind of ideal user profiles, right? Whereby you basically have a description of, well, this is a typical buyer of blah, 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 this type. And so therefore, as part of your sales enablement training that you go through for a new product launch or something, they'll give you this archetype. I'm here to tell you it's as useful as a two-tone PowerPoint template. It is not going to help you in terms of actually addressing. Yeah, it can give some clues, and it's useful from a training perspective to try and get there. But I think one of the things that you have to do, and this is an opportunity to use AI to your advantage, is there are ways and techniques that you can actually build much more specific ideal user profiles for the type of buyers you'll encounter. So think of all those committees I described. They're all staffed by archetypes who are actually real people. So as you are researching an organization, if the campaign is valuable enough to you to put in this effort, you should actually go and look and pull their LinkedIn profiles, their resume, if you can find it. If they're a clinician, you typically can find clinician CVs out there and pull all that information in, and then use the instructions that might be used. And maybe this is something that you talk to your product management leaders about. Use the information you've got of from your archetypes and then apply it against those real people in the organization and say, hey, ChatGPT /Claude /Comet which, name your GPT of choice.
Yeah.
Here's a prompt that actually says, I'm trying to create this, and this is what I'm trying to do. This is who I'm selling to. This is their profile. Upload document and actually say, help me tune my messaging about my product that I just told you about to be able to talk to and address the potential objections this person may come up with. So have those talking points ready before you ever go and set foot in the organization, so that you can be much more accurate in terms of what you're trying to do, rather than just relying on, well, I got taught these 15 objection responses.
Compliance Charlie says that he's going to be worried about this, and analytics Anna is going to be concerned about this.
Exactly. And so I think that's something that people, where you can actually use AI in your work life to try and be much more successful and powerful as soon as you're ready to have that interaction with that person.
So, Dad, in the next 10 years, obviously we don't know we can't predict which companies are actually going to blow up, right? Because we would buy their stock and we would not be doing this podcast. We would be on a island sipping some drinks.
Yeah, that'd be nice.
But we can talk about what we think the overarching trends are going to be.
Yep.
And I mean, off the bat, I've got to imagine that in the next, I'm thinking even 6 months, as the new kind of administration gets into place and really starts to dive down into health. They've already said a lot of stuff about interoperability and all these different pieces. I've got to imagine that an AI regulatory crackdown is going to come at some point. And you can even look, the NHS posted an incredible guideline about ambient scribing. So very, very particular AI use case. And if you read it, it can be generalized for all things artificial intelligence, because it's looking at things like, where is that data coming from? Where is it being stored? What is happening to that data? All the things that AI does, because it's got to whoop up to the cloud and whoop back down. Look at that NHS guideline. If you are either in a hospital and you're trying to figure out what's going to happen, or if you are a seller, those are the kind of questions that you're going to be getting asked very, very soon. It's a wonderful, wonderful place to start if you are a AI skeptic or an AI lover. It's just a really great guideline that they pulled together.
Yeah. And I think there's going to be more of those, for all of the kind of reasons I touched on earlier on, that obviously at a federal level, there's various types of regulations / enablement coming in, even sort of like changes that sort of Dr. Oz and the administration, are being talking about in terms of Health and Human Services. They've been talking about trying to mandate automating and making smoother, quicker, easier prior authorization. That's going to happen at that level. Now, I have a whole bunch of opinions about that. Bethany and I were chatting a bit earlier on, and we have two very different viewpoints on it, which is exactly, and both of them are exactly right. But we'll maybe save that for another podcast. But I think they're going to have that level of regulation. But then you're going to have the state level of regulation.
California already does.
Yep. And then you're going to have the health system level, the knights who say no, that level of compliance management. And I think that I'm working with our enterprise architecture team. And one of the things that we're looking at is, how do we police against our architecture and so on and so forth. It is chaos, even for an organization as large as the one I work for, and that has, a lot of resources available to it. They have got a real challenge, because if you take the example Bethany referenced earlier on, going from 80 AI widgets to 200 in the space of 7 months, how do you validate where all that data is flowing? How do you validate that the models that are underpinning some of these, because understand a lot of these AI widgets are built on another company's model and widget, and then had some secret sauce applied to them to make it relevant to that workflow. And so when you look at that, you're not even dealing with the end part of the machine that is doing a lot of that calculation and that thought process and machine learning on your data to be able to apply it. So what do you do from a governance and compliance perspective to try and track and look at all of these models that are suddenly in your ecosystem? And how do you manage them? How are you going to deal with all those data flows that are suddenly seeping out of your organization And I got to tell you that the organization I'm part of is very, very concerned about that, because they are very proud of their data. They know that the history of their data is worth an enormous amount to them from a research perspective, from an operating perspective, etc. So they're like very concerned about data leaking out through some of these side doors to be able to go, just because they're being it's being consumed by one of these AI widgets. And I think this is the landscape that is going to dominate the conversation over the next 12 months.
Agreed. I worked for a company that sold governance, risk, and compliance solutions. And I think when we're talking about AI, everyone's thinking about the sexy AI, right? Like the sexy AI where you can speak and like the words appear magical, or, you can get a imaging done and it can detect within seconds if you're having a stroke. Amazing. Super sexy. If it can save my life versus waiting for someone to look at it, and you can give me that medicine and you save my life with AI, incredible. And those are great solutions. But until I was selling GRC solutions, I didn't realize the unsexy software is very, very powerful in a health system.
Exactly.
And they spend a lot of money on the unsexy software. I was in the interoperability space. Nobody thinks about integration engines. It's like the pipes in your wall. My pipes work. I don't know who made my pipes. They bring me water. I know that I have a nice faucet and I can like wave my hand and water comes out, and that's magical. But I don't care about the pipes unless my pipes break or suddenly your sewer line explodes and like, oh no, my water, my data is everywhere outside. That's not good. I don't want that outside of my house. And so those unsexy pieces of software are very, very important in a health system, in a hospital and a clinic. And so I've got to imagine as AI becomes, as these solutions just become so enmeshed, and every doctor is screaming, I need this, I need that, I need that. And not just the doctors, but the supply chain folks and legal. Everyone is using AI. Well, it's not just in the clinical
Everybody
sphere.
is obsessed about PHI, quite rightly, in terms of, from a confidentiality perspective. And that's another topic for another day in terms of who owns the patient's data. Interesting. Lots of viewpoints about that. And also that's very regional. But confidential business information, CBI, is just as important, because that is oftentimes the health system's secret sauce of how it operates and how it's able to be successful or otherwise in terms of its endeavors. So that CBI leaking out suddenly becomes highly relevant. Think of all of the kind of sort of like personal information that might be there that is about your employees. Think about it being some of the intellectual property that's being created by some of your employees. It may not have patient information in it, but it is very unique and specialized and truly intellectual property. And yet that can leak out because some researcher decides they're going to put it in ChatGPT, and suddenly it's off and is part of training the model. So there's a lot of concern in that area. And I think if you wanted to start a business or you wanted to find the next big thing to sell,
you should start a podcast.
Start a podcast.
Right? Is that the answer?
I wish. I don't know where the money's coming from. Insert advert here. But I think that that's going to be an area that is going to explode. People looking for governance sort of solutions that are actually managing that, a bit like some of the compliance solutions that exist already for some other areas, but being able to track that and then being able to embed that. And I know ServiceNow and some of those companies who do manage some of the internal, sort of IT assets. There's another company that I really like called RDoc, who are doing some amazing stuff. Swedish company. I know you like Swedish companies.
Love Swedish
And,
companies.
and so from that perspective, and I don't mean IKEA, by the way, folks, but I do think that those kind of technologies are going to become increasingly important because, as Bethany says, yeah, it's the plumbing. But guess what? When the plumbing's broken, it messes up everybody's life. So I think that that's where there's going to be a lot of focus on how do we try and sort of make sure that we've got control over all of this AI technology as we go forward. And if I was looking for a job, selling job or a product management job, I would be looking in that area. And if I was an innovator that had an inkling of how to work around those workflows, that's who I'd be trying to convince. So VCs, be looking at those platforms. They might not be sexy. They might not get you on CBS News.
No.
But my goodness, I think everybody's going to be looking for that over the next probably couple of years.
Yeah, I completely agree. And if, we just need some of them to hit so that we can make a lot of money. So
Exactly. All right. So do you want to wrap us up here, Bethany?
Yes, absolutely. So thank you so much for listening. If you enjoyed this, please make sure that you share it with all your friends, your peers, your colleagues. Put it in that Teams chat, in your Slack channels. There's these two Scottish weirdos talking about healthcare technology. But our next episode, we are going to drive a little bit more into our personal work experience. Dad has been selling healthcare technology for 30, 40 years.
Let's call it 30.
Not 40. 30. We'll go 30.
Yeah.
I have for coming up on 12 years now, about half the time. But we're going to talk a little bit more about our own experience and around negotiations.
Yeah.
How have we approached deals in the past? What has worked? What hasn't worked? What are some of our tricks? What do we think, as we were just saying in today's episode, in 2025, it's different than even last year. So what are the techniques that we think are really going to stick around and we're really going to lean into and see more of in the future? It's going to be fun.
It will. And, I think that for all of you who have joined us, I really appreciate you coming and joining. As I say, if you would comment, give us some feedback about what we've covered here today. If you've got a different point of view, tell us. We'd love to hear from you. So, go ahead and comment down below, but like and subscribe help us in terms of growing the channel. But the other thing is feel free to reach out to us either through the comments or through any other messaging format. And we look forward to seeing you on the next episode. But until then, keep havering.